Hello, my name is Robert Hamilton, co-founder and chief scientific officer of NovaSignal, and I'm very excited to introduce our next installment of our webinar series with Dr. Jonathan Tobis. Dr. Jonathan Tobis is Emeritus Professor of Medicine at UCLA and the Director of Interventional Cardiology. He was a member of the Board of Trustees of the Society of Cardiac Angiography and Interventions. In addition to performing complex coronary angioplasty, Dr. Tobis is involved in the catheter-based treatment of structural heart disease, including closure of PFO, atrial septum defect, among several others. Dr. Tobis is a leader in digital angiography for the use in cardiac catheterization. In addition, he helped to develop the first mechanical rotating intravascular ultrasound imaging device. His recent work has been devoted to understanding the role of PFO in the relationship to cryptogenic stroke, migraine headaches, and other conditions. Finally, Dr. Tobis recently co-edited a textbook on PFO closure for a number of different pathologies and conditions as well. So we're very excited to introduce him today on his talk for transcranial Doppler for the evaluation of PFO. Dr. Jonathan Tobis.
Thank you, Robert. It's a pleasure, everybody, to be able to speak with you. I have a lot of enthusiasm for using transcranial Doppler, and I'd like to see it used more often around the world for making diagnosis of PFO. And so I'm going to share with you some of the data why I came to that conclusion. Let's start out with this case example. See if I can move this. Good. This is a patient that I saw this past year, a 37-year-old occupational therapist who had had migraines since she was 23 years old, occurring about once a week, associated with visual aura consisting of scotoma. She also complained of dyspnea and lightheadedness when she exercises or strained. She had a transthoracic echo in 2013 at an outside institution, and that did not show any evidence of shunt. She had a repeat transthoracic echo in 2022, and I'm not sure what the reasoning was why they decided to repeat the bubble study. But someone did, and it showed a significant shunt this time, which demonstrates the poor reproducibility of transthoracic echo. She then came to see me. I heard the story of the lightheadedness and dyspnea with exercise, so we got a treadmill stress test, and we measured the oxygen saturation every minute during exercise, and she desaturated down to 83%. Consistent with her symptoms. Then, even though she did not complain of any neurologic deficits, I like to get a brain MRI on these people just to determine if there's any silent stroke, which you will see sometimes. So if there is a PFO in this patient, the indication for closure would have been a congenital right to left shunt, a form of cyanotic heart disease, with hypoxemia. We got a transesophageal echo, and the report says there is no evidence of a patent foramen ovale. She had a total of 5 10 milliliter saline contrasts injected. While supine, she had 2 at rest and 1 with Valsalva. While upright, she had 1 at rest and 1 with Valsalva. So I asked the TE people actually to do these studies supine and upright because of orthodeoxia platypnea. So they did that, both supine and upright, and there was appearance of bubbles in the left atrium after 5 beats with rest and with Valsalva, suggestive of an intrapulmonary shunt. So they said that there was no PFO, that this was an intrapulmonary shunt. That's their conclusion. And the diagnosis of PFO by TE usually depends on the bubble study. The echo people tell me they don't really look at the flap opening of the septum primum from the septum secundum because most of the time the flap is closed. So they're really dependent on the bubble study when they're doing a TEE. So this brings up the question of what do late bubbles really mean? And we'll talk about that. Based on their interpretation that these late bubbles meant that there was an intrapulmonary shunt and they didn't see a PFO, we obtained a CT pulmonary angiogram, and that did not reveal any pulmonary AVM. So the question is, okay, now what do you do? Is the TEE correct, or is the transthoracic echo correct? The patient was symptomatic with oxygen desaturation. It really brings up the issue of what is the gold standard for determining a PFO. So the next step is we got a transcranial Doppler, and the transcranial Doppler showed a large shunt, Spencer grade 5, too numerous to count. So is this a PFO or is this a PAVM, even though the CT is negative? So you've got these different opinions based on different testing that's done. Here's the baseline TEE. It shows an atrial septal aneurysm, which is very helpful, but a negative bubble study, or at least late bubbles. And then I don't know if you can see it on the right-hand image up here, but there's a little, I'd have to slow it down for you, but there's a little dot of Doppler flow going where the PFO would be. Pretty small, but suggesting that there's at least a little left to right shunt. The other comment I'd like to make in terms of when you see an atrial septal aneurysm is that I've never seen an atrial septal aneurysm without there being a PFO. And that's because I take these people to the cath lab and we probe the septum, and I've always found a PFO if there's an atrial septal aneurysm. In the literature, you'll see that there are categories of atrial septal aneurysm without a PFO. And I think that's a misdiagnosis because it's based on an echo and not on heart catheterization. So we took this lady to heart cath, and we were able to pass a wire across the atrial septum into the pulmonary vein. And then we did balloon sizing. So this is the left atrium. This is the right atrium in the LEO projection. This balloon sizing, it's an Amplatzer 24 millimeter balloon. So the distance between this marker and this marker is 15 millimeters. So this is about a 10 millimeter diameter PFO. And this is not a small PFO. And here's we close the PFO with a cardioform device. This is before it's released. This is after release. You can see the significant change in orientation from more horizontal to more vertical. And I don't know if that made a difference in terms of why it was difficult to visualize by TEE, but that's a possibility. So the take-home points from this case is that the TEE misses a PFO in about 10% of cases. Transcranial Doppler is more sensitive than either transthoracic echo, which is about 50% sensitive, or TEE. And the timing of bubbles is usually misleading. So we've done 2,000 transcranial Doppler studies, and in the ones that are positive, a PFO is present 99% of the time. Only 1% are due to a pulmonary AVM. This is true unless you have hereditary hemorrhagic telangiectasia, in which there are AVMs throughout the body, including the lungs. And so in HHT, it's very highly likely that you have a PAVM. But if you exclude that population, which is pretty simple based on their history, no epistaxis, then 99% of positive TCDs are due to a PFO. So I think the way that echocardiographers interpret these studies is misleading in a large percentage of time, both on the presence of whether there's a PFO and the late bubble studies. The late bubbles really just means when the bubbles get to the superior aspect of the right atrium, and then when the flap opens up. So if the flap's mostly closed, the bubbles can just be sitting there, and it looks like late arrival, but it's just when the PFO opens up. So if the clinical scenario suggests a PFO, and the transcranial Doppler is positive, either grade 3, 4, or 5, but the TE is negative, then what I do is I take the patient to the cath lab and I probe the septum, and almost always there is a PFO. I just wanted to describe this paper that we wrote, a comparison of echo and transcranial Doppler to determine patent foramen ovale size. And we compared it to heart catheterization, where we crossed the septum and performed a balloon sizing. So it's balloon sizing versus echo versus transcranial Doppler. So just to review the echo measurements, if you're using ICE, it's a flipped image compared to transesophageal echo. So transesophageal echo, which most of you are probably familiar with, the left atrium is on top, the right atrium is behind, and you have the septum primum, and then on top of the septum secundum. And the PFO length is measured as the distance of the septum primum as far as you can see it overlapping the septum secundum. And the PFO height is this distance between the primum and septum, if you can visualize them. The converse is true in the ICE image. The probe is in the right atrium, and so what you're seeing is the septum primum, which goes behind or to the left of the septum secundum. The same measurements, though, for length and height are used. We did a study in vitro. Here's an autopsy specimen of a heart with a sizing balloon through the PFO. And here's the PFO width, which is parallel to the plane of the atrial septum, and the height perpendicular to the plane of the atrial septum. In vivo, here's a balloon sizing catheter across the atrial septum. This is the left atrial side. This is the right atrial side. And this is a circular PFO. So the X-ray image is parallel to the plane coming in and out of the picture of the plane of the atrial septal wall. And what you're imaging in the LAO view is the height of the PFO. And in the RAO view of a circular PFO, the plane is perpendicular. The X-ray image is, or the X-ray plane is perpendicular to the anatomical plane of the atrial septum. And what you're visualizing in the RAO view is the PFO width. In those non-circular PFOs, this is the LAO. You can also see the length of the tunnel compressing the balloon. This is the PFO height versus the PFO width. So it's a little asymmetric. The width is greater than the height in non-circular PFOs. So that's how we define the width of the PFO. And then we had a comparison between measurements of TE versus ICE in terms of PFO length. They're pretty close. The TE, I think, is a little bit better imaging and shows a longer length, 13 versus 10. Not clinically significant, but there are some differences. If you look at the PFO height by TE versus ice, pretty close, 1.5 millimeters, and by TE, if you compare TE versus sizing balloon in these 56 patients, they're very different. The TE estimates a height of 1.5 millimeters, whereas by balloon was 10.5, and similarly, ice versus sizing balloon, very different. So echo underestimates the size of a PFO, either by TE or intracardiac echo. And if you do this Bland-Altman plot of the PFO height by a TE versus the sizing balloon, then you see that there's not, usually with Bland-Altman plots, the line is fairly linear. This is not, and this shows the bias, so that as the PFO gets larger, there is the TE underestimates the true size even more. So it's PFO size dependent. This is a plot of PFO height by sizing balloon on the x-axis versus the transcranial Doppler with Valsalva. And you can see that in this quadrant, you have a large PFO by balloon sizing and a large TCD shunt. In this quadrant, it would be a smaller PFO and also a smaller shunt. But there are a lot of studies where there's they're uncoordinated. They don't correlate very well between the size of the PFO and the size of the shunt. So the TCD correlates poorly with PFO balloon sizing, but there's some correlation, but that's this line, which is the correlation. But the TE size has no correlation with transcranial Doppler. Again, just to be aware of what the different techniques that we use are telling us and how they correspond to each other. Let me show you this case example, which demonstrates how large the shunt across a PFO can be. This is a 70-year-old woman who had migraines since she was a teenager. For some reason, as she got older, she developed right hemidiaphragm paralysis. And with that, we believe the PFO opens up, and she developed platypnea orthodeoxia, where her oxygen saturation lying down was normal, 96%. When she stood up, it dropped down into the 80s. So here's an injection from the inferior vena cava. And the blood flow, as I'll describe later in a diagram, is predominantly from the inferior vena cava across the PFO. So if you really want to demonstrate a PFO, it should be injections from the inferior vena cava. That's difficult to do outside of the cath lab, so most of the bubble studies are done from the arm. But you see there's a lot of blood going back into the left atrium. To clarify where the septum is, look at the study that we did after we closed the PFO. So here's an Amplatzer device in the PFO. Nothing is going backwards now into the left atrium. This is in a lateral projection. So you can see the enormous amount of blood flow that's going at rest across her PFO into the left side, inducing this hypoxemia. After we closed the PFO, the hypoxemia was relieved. She had normal oxygen, either lying down or standing up, and also her migraines went away. So I'd like to show a couple of examples of how we use transcranial Doppler to diagnose PFO. And this is one of the most enjoyable research studies I've ever done in my career. This is Mount Whitney in California, the highest mountain in the continental United States, 14,500 feet. And we're doing a study of acute mountain sickness. And the first paper that suggested that mountain sickness, or HAPE, high altitude pulmonary edema, was associated with PFO was this study by Aleman up in the Alps. They have a very nice laboratory at high altitude. And they took 16 experienced professional mountain climbers who had had an episode of high altitude pulmonary edema versus 19 people who had never had an episode of high altitude pulmonary edema. And what they found is that the PFO incidence was higher in this group who were HAPE susceptible versus those without it. The difference at low altitude versus high altitude, they claim, is due to the PFO opening up at higher altitude, but it shows you that you misdiagnose a number of PFOs if depending on your technique. So I'm not sure if this was done by TEE or transthoracic echo. Also, the arterial saturation was lower in the HAPE susceptible group. They had the larger PFOs had lower arterial saturation, and the PA pressure was higher in those who had the PFO and were HAPE susceptible. There's also this very elegant study by Hackett in the 1970s, where he went to Mount Everest base camp up here at 17,500 feet, I believe. And he studied 278 climbers. Over half of them who rapidly ascended developed acute mountain sickness. So what you can do is you can fly from Kathmandu to Lukla, which is about 9,000 feet, and then you start hiking up. Whereas those people who hiked the whole way acclimated as they went higher and higher and were less likely to develop acute mountain sickness. Acclimatization is important in acute mountain sickness. He did not look for the presence of PFO. So to understand what was going on with acute mountain sickness, I climbed to the highest place on Earth, Everest. I didn't make it all the way up to Everest Base Camp because we didn't have enough time, but this is at 15,000 feet at Amadablan Base Camp, which is another very high mountain that a lot of people climb. I do not do mountain climbing. This was just trekking. These are the parents of the Sherpa that was our guide that we hiked with, and he had climbed Mount Everest before. And what I decided to do to study this was to go to Mount Whitney and recruit hikers who were doing the John Muir Trail or just going up from Whitney Portal, which is at 8,000 feet, up to Mount Whitney and back, usually in 1 or 2 days. And so this is me sitting, I camped out for a week at 12,000 feet. This is the John Muir Trail right here. And so I would accost hikers either going up or back and ask them to participate in our research study. And so they would fill out an acute mountain sickness questionnaire, and then they would go to the little hospital in Lone Pine, which was very generous in letting us set up a portable transcranial Doppler machine there. And we enticed these hikers who were starving and exhausted by, if they went through this procedure, we would give them a $25 gift certificate to the local pizza and beer place in Lone Pine, California. So we had, I think, 130 35 subjects. So this is the ER in Lone Pine doing transcranial Doppler testing. So here's the headband with the ultrasound probes on it. We use this tube attached to a manometer, which is up on the wall. So the patient is looking at the manometer to keep the pressure at 40 millimeters of mercury. So you know that they're performing an accurate Valsalva maneuver. This is the IV. We draw back blood into the syringe. These are the two syringes to go back and forth, and the blood proteins make the bubbles stay in solution. Whereas if you just use saline, the bubbles come out immediately. Basically, you're injecting large air bubbles. So this procedure is very technique dependent. And with our technician, we had very reproducible results. These are the grades of TCD. I assume most of you are familiar with this. And the important point here is that when you take these patients to the cath lab, we found that those people who had a grade 3, 4, or 5 had a clinically significant PFO, whereas patients with grade 1 and 2, there might be a PFO, but it was like very small, a few millimeters. And I believe that grades 1 and 2 TCD correspond to the pro-patent PFO at autopsy. So the autopsy incidence of PFO is higher than what we find clinically, because their definition is, can you get a probe across the PFO? So 1 millimeter probe. Whereas clinically, you want to know, can a blood clot get across the PFO? And that's a grade 3, 4, and 5. So that's where we came up with 20% incidence of PFO in a control population versus what the autopsy studies show. And getting back to the acute mountain sickness, there's the prevalence of PFO in hikers was higher, 63% or something, versus those subjects who didn't have acute mountain sickness. It's interesting, there's a high incidence of PFO even in that group. So presumably they acclimated. They may have come over the backside of Mount Whitney and had been on the John Muir Trail for weeks. And so they were less likely to develop acute mountain sickness. So this brings up the issue of what is the true gold standard for diagnosis of a PFO. Here's an article comparing transcranial Doppler versus transthoracic echo for detection of PFO in patients with cryptogenic stroke. Systematic review, acute accuracy by meta-analysis. But when you read the abstract, the sensitivity and specificity measures of TTE, TCD, or both were compared to the gold standard of TEE. But TEE itself is not the gold standard and can be wrong in diagnosing a PFO in up to 10% of the cases. This is another article that you might find useful, the detection of patent foramen ovale, also describing transcranial Doppler and the Valsalva maneuver. And I bring that up just to show you that the Valsalva maneuver is fairly complicated. These are the blood pressure changes, and the Valsalva maneuver is actually separated into 5 stages. So those of you who are interested in this, I refer you to this article. You can spend some more time going through the different stages of the Valsalva maneuver. The important part for diagnosing PFO is that it depends on the release of the Valsalva maneuver. So when you're bearing down, you're preventing blood from entering the thoracic cavity. When you release, there's this torrent of blood from the inferior and superior vena cava into the right atrium. That increases the right atrial pressure, opens up the PFO, and that's why you get this shunt seen at that time after the release of the PFO. Here's another example of using PFO, not using transcranial Doppler to diagnose PFO. We wanted to look at those people who had sleep apnea and ask the question, what's the incidence of PFO in that group? So we had 100 patients with sleep apnea, and we measured, did a transcranial Doppler. The frequency of positive transcranial Doppler, which can indicates that there's a PFO, was 42%, whereas in our general population of controls, the incidence of PFO is 20% by transcranial Doppler. Our control population are patients who were coming to the cath lab for a diagnostic heart cath who did not have congenital heart disease or heart transplant. It's a control population of convenience. They're sitting in the PTU waiting for their heart cath or after their heart cath. They have an IV in, and it's no big deal to them to say, yeah, sure, go ahead and do a bubble study on me. So that's how we get our controls. Anyway, there's a higher incidence of PFO in sleep apnea patients. The nadir of the oxygen desaturation was similar, whether or not you had a PFO, but the degree of oxygen saturation for the amount of apnea, there's this index, the oxygen desaturation index over the apnea hypopnea index, is different if you have a PFO or not, so suggesting that those people with a PFO develop more symptoms or become more symptomatic with their sleep apnea at an earlier stage because they're desaturating earlier than the severity of the sleep apnea itself. Switching gears to the cryptogenic stroke studies that have been done with patent foramen ovale. This is a meta-analysis that I did with Bernie Meyer and my research associate, Dr. Mojadidi. And here's a forest plot of the benefit of PFO closure in people who had a previous stroke, suggesting that closure is preferable to medical therapy. But the incidence of atrial fibrillation is worse, is higher in people who get their PFO closed. This turns out to be a nuisance, but not a major problem, but I do treat this with anticoagulation after their PFO closure. But I use transcranial Doppler to look at the residual shunt rate. So here's a couple hundred patients who had their PFO closed, and the frequency of residual shunt rate is different depending on which device you use. So this is over a number of years, depending on what device was available. The cardioform, we find, is the most effective complete closure based on transcranial Doppler. So using the most sensitive tool to pick up residual shunts. So again, when you read the literature, if their residual shunt rate is based on transthoracic echo or transesophageal echo, they're missing some of that residual shunt. But if you use transcranial Doppler, which is picking up almost all of them, you have complete closure with the cardioform device, and then different closure rates down to about 15% residual shunt rate with the Amplatzer PFO device. The price you pay for that improved closure rate is a higher incidence of transient atrial fibrillation in the cardioform device versus other devices. So there's a trade-off, but my preference is to have complete closure. So let's talk about why you have a PFO anyway. Here's the pathway of the PFO. of the blood flow coming from the placenta. So in utero, the lungs are not working. So to send blood to the lungs, you would continue to lose oxygen. The placental oxygen saturation is low to begin with. It's only 67%. If the blood went the normal pathway through the lungs back to the left heart, it would be much lower than that, and presumably could not sustain life and the development of different organs, including the baby's brain. So the oxygenated blood from the IVC is shunted across the PFO using the eustachian valve as a way of directing the inferior vena cava blood across the PFO. This is so important that it's preserved in all mammals. It's preserved throughout evolution to have a PFO. And as we've said before, we find that 20% of adults have a PFO. So presumably 20% of all humanity, about 1 billion people, are walking around with a PFO. So it's the most common congenital heart defect, as far as I'm concerned. Most of the time doesn't cause a problem. We estimate that about 1 in 1,000 people per year with a PFO have a stroke. Here's the anatomy, the septum primum, septum secundum, and the closure of the PFO. The residual indentation is the fossa ovalis in people where it's closed. There have been a number of conditions that have been associated with PFO, certainly cryptogenic stroke and migraine with aura. You're all familiar with that. We talked about the case of orthodeoxia. You can have acute embolization to the coronary arteries and cause acute MI, decompression illness, high altitude pulmonary edema we discussed, obstructive sleep apnea exacerbation. There's some reports of Raynaud's spasm. I believe that coronary spasm is also induced in some patients with the PFO and right to left shunting of blood. The presence of brain abscess. There are a couple of reports about epilepsy or syncope of unknown cause being associated, being a higher frequency of PFO found in those cases. The unifying hypothesis for all these conditions is that some venous material, either thrombus, platelets, nitrogen bubbles, low oxygen, bacteria, or chemical, bypasses the lung and enters the arterial circulation through a PFO. Here's a typical example of a patient who presented with a sudden stroke, and walking along the street had all of a sudden aphasia, no obvious disease or cause of the stroke after an extensive workup, and the TE shows an atrial septal aneurysm and PFO. And you can see the PFO is not a hole, it's this tunnel between the right atrium and the left atrium. The association is that 60% of people with cryptogenic stroke have a PFO. But if you ask the question, how many people who had their cryptogenic stroke also had migraine with frequent aura, 93% of those people have a PFO. So the mechanism of is based on these clinical trials for stroke is due to paradoxical embolism through a PFO. Occasionally you see the thrombus. There's a large thrombus from a DVT straddling the atrial septum. This is a case at autopsy with the thrombus, which is trapped in the PFO, but it's been cut off, and unfortunately the rest of the thrombus went up to the brain and caused a massive stroke in this person. So most of the time, the diagnosis of PFO or cryptogenic stroke is a diagnosis of exclusion. You don't see the thrombus. So it's the neurologists say only if you see the thrombus do you know for sure that this was the mechanism. Otherwise, it's a diagnosis of exclusion, and they weigh the risk of atherosclerosis being present versus a truly cryptogenic source. So you have to, when you're working up these patients, you have to rule out other major causes of stroke. As I said, I get an MRI to look for clinically silent stroke. And then I assess for right to left shunting, and the TCD is the most sensitive screening tool. So that, I think, should be the first study that the neurologist should do, and that's what they do at UCLA. They get the transcranial Doppler with the provisos of technique that I described. The other reason why TCD, I think, is more sensitive than echo imaging is that echo imaging is a tomographic study, and you might miss the bubbles in the left atrium depending on the plane that you're looking at with your echo sector. Whereas a TCD, you're looking at the entire volume of the bubbles in the artery. So I think that's another reason why it's more sensitive than echo measurements. We then get a TEE. I think a TEE is very helpful to me anatomically. I want to make sure there's no ASD, no sinus stenosis, whether there's a septal aneurysm or not, before I take this patient to the lab to close the PFO. You have to exclude atrial fibrillation, and we get hypercoagulable labs. There's just some points I'd like to make about PFO and its diagnosis. I think we've talked about this before. The TE can be misleading if the number of bubbles is small, because the neurologists have said, oh, small number of bubbles, therefore this is a small PFO, therefore this PFO could not have caused this stroke. And I have seen that multiple times in referrals from neurologists, and I think that's absolutely incorrect. It's very misleading, and they're basing it because they trust the TTE interpretation, which I've tried to show you does not correlate with the PFO size, does not correlate with transcranial Doppler. The timing of bubbles we've talked about before. Late does not mean transpulmonary. The TE underestimates the PFO size. And as I said, a small PFO is not too small to cause a stroke because they're underestimating the size. So it's not really a small PFO. And then we talked about this before, that most of the time a positive TCD means that it's a PFO. And that the true gold standard for diagnosis of PFO is a right heart catheterization with the guide wire crossing the septum and not an echocardiogram. I would recommend that you be skeptical of all literature that uses echo to make the diagnosis or exclude PFO, because you're categorizing patients and you're putting them in two different groups. And if your diagnosis is incorrect, then your conclusions about PFO are incorrect, or at least not completely accurate. So that's why it's important to use TCD, the most sensitive technique, to make the diagnosis, to separate those groups, this group with or without PFO. And I think part of the problem is that echocardiographers don't work in the cath lab, and they don't see those patients that have had negative TEEs that I've taken to the cath lab and proven that they have a PFO. So that is the true gold standard. I think we talked about this before. The PFO is, I believe, is the most common congenital heart defect. So it's 20% of all people. But if you look at the probands, we did a family study of like 50 different families and looked at their first-degree relatives, their parents, siblings, or children. 60% of first-degree relatives have a PFO. So PFO is hereditary. We've done some studies looking at what potential genes might be involved in whether or not you have a PFO, but I think that's why the PFO is there and doesn't close. It's determined by certain genes. And then, although the incidence of PFO in the general population, of stroke is 1 in 1,000 per year, after the first stroke, the rate of recurrent stroke is 1% per year, which doesn't sound that bad, but it's cumulative. So over 10 years in the clinical trials, the incidence of recurrent stroke was 10%. We don't know, do you extrapolate this over 20 years or 30 years? Is it continuous 1% per year? But the possibility is there that over a person's lifetime, they have a stroke when they're 20, they're going to have a 50% incidence of stroke in the future. We certainly see people who 30 years ago had a stroke, no diagnosis was made, no workup was done, no bubble study. Then 10, 15 years later, they have a second stroke. Then they come in at age 75 with a third stroke, and a diagnosis of PFO is made. So even though they're 75 years old, that third stroke, the second and the first stroke, were probably due to right to left shunting, paradoxical embolism through their PFO. So that's why I do not limit PFO closure to only patients below age 60. And the randomized trials show that PFO closure is preferable to medical therapy. We talked about this point before. A lot of those strokes are facilitated by thrombophilia, most commonly birth control pills. So 50% of the women that we've seen with stroke were on birth control pills. And then straining and venous stasis also predisposed to these blood clots. So it's the venous blood clot, and the pathway is the PFO. So I'll leave you with a couple of hypotheses. I think that almost all strokes that occur in young patients with migraine are caused by a paradoxical embolism through a PFO. Migraines themselves do not cause stroke, which is what I was taught when I was in medical school, that it was due to intense vasospasm. That has been disproven. The amount of vasospasm you get is 20%, a decreased flow, which is not enough to induce an infarct. But the migraines are the clue that there's a PFO present, and that patient then had a thrombus, which caused the stroke. The second hypothesis is that I believe that almost all strokes that occur in young women taking birth control pills are caused by paradoxical embolism through a PFO. Estrogen does not cause arterial cerebral thrombosis. Estrogen predisposes to venous thrombosis, which then embolizes. And the corollary of that is that there's known an increased risk of stroke in migraineurs who take birth control pills. And that's because the migraine tells you that there's a PFO pathway, and that then the birth control pills increase the incidence of venous thrombosis, which then embolizes paradoxically through the PFO. None of these studies of birth control pills or migraine have looked at and stroke have looked at the incidence of PFO. And I believe if that were done in a prospective way, that you would see that almost all of these strokes are associated with PFO. So in conclusion, for any investigation of PFO-related conditions, I think it's essential to maximize the accuracy of identifying those patients with or without a PFO. And the best tool to do this is transcranial Doppler, which is the most sensitive method to identify a right to left shunt. Here's the book that Robert was suggesting. So if you want to delve into this deeper, this is the book that I wrote with Khalid Mojadidi and Bernie Meyer. So I hope you enjoy it. Thank you very much for your attention.
Thank you, Dr. Tobis. There's a number of questions. I know we have some limited time, but very interesting research studies. I'm jealous of the the ability to go do research outside of a lab setting. So that must have been very exciting. So we'll jump into some of these questions. I'll jump around a little bit because I believe you've answered some, but we'll make sure to address all of the questions. So one of them had to do with the sequencing of your tests, and you briefly mentioned it at the end of whether it's TCD or not. So the direct question is, if you're doing the TCD bubble study first, if the TCD is positive, a large grade 3, 4, or 5, do you then never do a TTE bubble study? Or in what situations, if you had a large PFO on TCD, would you do a TTE bubble study?
So I would recommend doing a TCD first, because that's the screening tool. If the TCD is positive, then I get a TEE. Again, these are in patients who've had a stroke. So you want to know, is there a clot in the left atrial appendage? Is there some structural heart disease? So a TEE for the anatomy is very useful, okay? And the other conditions that we talked about before. But a TTE isn't going to add anything. So I get a TCD and then a TEE. We used to send patients to the echo lab with a transthoracic echo and ask for a bubble study. And then what we found out is that if the bubble study was negative, the patients were then sent for a TEE. This is before we were doing transcranial Doppler. And so the echo lab said, we're not going to do transthoracic echoes anymore because you always ask for a TEE if it's negative, because you don't trust a negative transthoracic echo. So it was the echo lab who actually said, stop doing transthoracic echoes.
The next question is, when you were testing for the effective closure rates using TCD, did you only use grades 3, 4, and 5 for residual shunting, or did you include any grades 1 and 2 as well?
I believe it was 3, 4, and 5 as a significant residual shunt.
Okay.
If you have 1 or 2 bubbles, first of all, that might go through the device, but is clinically meaningless. And there could be transpulmonary transfer of a few bubbles. So it's grade 3, 4, and 5 is the criteria we use.
So, and again, I think you might have mentioned this, but I think it's probably relevant for in the overall workup of not only stroke, but the other conditions you talked about. What do you suggest the ground truth be in the study? You know, TTE, TEE, ICE versus TCD. And the individual said the perception of TEE as the gold standard is very strong. I know you're talking about right heart catheterization. How do you think about that from a study point or overall workflow point for these patients?
So again, it depends on the population that you're talking about. Let's assume that these are stroke patients. So they've had a stroke. And if there's a PFO, your plan is to close this PFO, right? So I have a low threshold for taking a patient like that to the cath lab, because if you make the diagnosis of right to left shunt of a PFO, you're going to close it at the same time. So we get authorization for PFO closure, then take those patients. That's only in the situation where there's some conflict between the different studies. Transcranial Doppler is positive, TEE is negative, is the common disparity.
Regarding balloon sizing, there's a question: doesn't PFO sizing balloon overestimate the PFO by stretching the septa? Aren't TEE and ICE seeing a PFO at rest and the balloon is stretching it out? Going back to some of your earlier questions, slides.
Yeah, the balloon is a soft balloon and it's done under low pressure. So I think all you're doing is really, you're opening it up. So how do you define the size of a balloon, the size of a PFO? This is the potential size. So when the blood clot gets to the right atrium and the patient bears down, that PFO then becomes not a 2 millimeter PFO by height, but is a 10 millimeter PFO, and the blood clot flies across. So that's what's clinically relevant. So I think the balloon sizing is more clinically relevant as an indication of the size of your PFO than resting echo where the flap is closed. As you know, because the echo people can't see the PFO open. They don't make a diagnosis of PFO because they see the flap open like this. They make a diagnosis based on their bubble study. So it's not even the anatomical image that they're using for TEEs.
I think we have a few more questions here. One is, what do you think of our echocardiograph-based dogma in the stroke literature of PFO is present in 30 to 50% of patients with embolic stroke of no source? I mean, I think you got to this in the end of your presentation, but do you think that this is an underestimate given TCD is not a part of these studies?
Correct. So what we did is we went through the UCLA stroke database. There are like 1,200 patients, and identified those people who had a diagnosis of cryptogenic stroke, and then looked at, okay, did they get a workup, which included a diagnosis of right to left shunt. I actually don't think that we isolated it only to those who had had a TCD. I think it was a TEE or a TCD. So granted that we're going to miss a few patients who had a PFO, but at least they had that evaluation. And our analysis showed 60% of people with cryptogenic stroke had a PFO. So I think 30 to 50 is an underestimate because they don't look with those techniques, either TEE or TCD. And then if you add on top of that, do they have a history of migraine with aura, then it becomes 93% of those people have a PFO with their cryptogenic stroke.
Yeah, that makes a lot of sense. One question, that I personally had was, you mentioned it in some of your learnings about, I don't want to say being skeptical, but being skeptical of studies that use different underlying diagnostic techniques for PFO, and then associated that with some condition. And in the one I've seen recently, looking at the Pascal scoring, as well as the PFO closure trials to get a better estimate of those, used TTE for that, but showed if you had a large shunt or large PFO, that it increased the likelihood of being able to diagnose those that, or whether or not the PFO was the underlying cause of that stroke. And so with that, is there room in future studies to revisit that? Would that be your suggestion, or that studies like that still have value? They just need to be aware that it is probably underestimated given TCD was not used as the screening tool for PFO.
Right. So if you do a transthoracic echo and it's markedly positive, huge amount of bubbles go across, there's no question that patient has a PFO. You don't need a TCD in that patient. But if you're doing a screening test, or you're diagnosing or saying something about the frequency of PFO in one group versus another group, you want to be accurate in terms of how you are diagnosing and distinguishing the group with PFO versus the group without PFO. And you can't do that with a transthoracic echo alone. And I believe you can't do it with the TEE alone.
Yeah, good. Well, Dr. Tobis, we're at the top of the hour.
Conclusions are going to be wrong.
Yeah, no, this has been fantastic. I really appreciate the time today, and a lot of thoughtful questions. And thank you very much.
Okay, thank you.